Hello. Welcome, everyone. Love for you to put in the chat where you're coming from today. Hello, hello. Welcome, welcome. We're just going to give it another few minutes as everyone's coming in. Oh, hello. LA. All right, we got some Palm Springs. Wow. Nebraska.
And I'm in Northern California too. So
Wow.
the West Coast is represented so far.
Way to go. And I am coming to y'all from Atlanta, Georgia, where it is raining. Charlotte. All right. Okay. All right, everyone. We are going to get started. So, hello, everyone, and welcome to today's webinar, part one of our series here called Not All DCIS is Risky. I am Megan Claire Chase, the breast cancer program director and host of our BC Life podcast here at Share. Plus, I'm a 7-year breast cancer survivor. Now, before the presentation begins, I'd like to tell you a little bit about Share for those of you who might be new. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with a breast or gynecologic cancers and provides outreach to the general public about signs and symptoms because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, podcasts, and our helplines, please visit our website at sharecancersupport.org. Now, we have a few housekeeping reminders for you. All participants will be muted during this presentation, but feel free to write comments in the chat and engage with each other. And don't forget that when using the chat, make sure to select everyone so everyone can see your comments. Once our fabulous speaker finishes presenting, we'll begin the Q&A discussion. Please submit any questions through the Q&A section at the bottom of your screen. And remember that our speaker is unable to give specific medical advice, so make sure to keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and select the subtitle option. This webinar is being recorded and we'll share the recording in a few weeks with all of the registrants, and it'll be added to our website. So now I would like to hand it over to Deborah to introduce herself. Deborah, the screen is yours.
Okay, well, thank you. So my background is I came from the computer industry, but I've been the president and founder of Patient Advocates in Research, which is an international informal communication network of those of us who are involved in research in some way. And that can be basic research. It can be clinical research, like clinical trials and things like that. It can be epidemiology, which is like population research where risk factors and things like that come from, patient experience research, and then healthcare delivery research. So it's really anything that can cover or touch a person, hopefully. And so I'm here to talk to you today about DCIS and the fact that not all DCIS is risky. And I'm going to see if I can share my slides now. Yes. And we will get started. I am also, just so you know, a breast cancer survivor and also a DCIS survivor. I've had two different breast cancers, one of which was surrounded by DCIS. So oops, I don't think the slides are being shared correctly. Hold on a minute. Let me try that again. Where did it go? Well, hold on a second. Let me see if I can get this working right. Don't usually have this problem, but there we go. Now it should work. Okay, is that correct, Megan?
Okay.
Okay, great. Um, So I work with a lot of researchers, as do, and I work as a team with them with what we call the patient leadership team and also um, a, a patient advocate team in different research programs that are deal with DCIS. So that's where some of this comes from, and I'll explain that. But first of all, I thought we'd start with what people really want to know about DCIS. Now, this is a screen that I often share, not just with you all, but also with the researchers. You know, that there, and DCIS is confusing. There are lots of opinions. There, you know, one question often people have is, aren't there any standards for DCIS? Well, yes, there are, but you'll see why it's a little confusing and why the standards aren't as clear as we'd all like them to be. DCIS, is it cancer or not? This is actually being debated in the research and medical communities as well. So we'll get into that a little bit. Will it come back and what happens to me if it does? What type of treatment to consider, you know, surgeries, radiation, active monitoring, all of those things. What is risk about? Because that's really what all the treatment is about for DCIS is there a way to lower my risk? And if so, what does that mean and what's involved and what kind of consequences are there from that? And then, you know, why, if this isn't cancer or is something I don't need to worry about as cancer, why am I being referred to all of these cancer doctors, right? And the terminology that's used and stuff like that. You know, family members, and why is it so confusing? So I'm going to try to answer some of these questions as we go through. But I'm not covering a lot of the new research today. That will be done in February, but we'll talk about that as well. So the first thing I thought I would start with is there are a lot of misunderstandings and there are lots of reasons for that. And so, you know, here are just a couple pictures to show you, you know, Harry Truman, this is a famous story that the paper said that he was defeated by his opponent for president when in fact he wasn't. So that was an example. And then there are also some COVID examples over here on the right. This is an organization that put together some information that they try to present in multiple languages, as you can see, to help people understand that where you get information isn't always mean that it doesn't always mean that it's accurate. So you have to be kind of careful and thoughtful about where that information is from and how you're going to determine where it is. And so we hear a lot about DCIS through media, sometimes through prior DCIS patients, message boards, et cetera, celebrities, even some healthcare providers. What I want to say about the prior DCIS patients is that it's not that they have wrong information, but they have information that's right for them. But everyone and everybody's disease, DCIS, breast condition, can be a little different. And so there are different options for that. So we're going to talk about that. There are some reliable sources, quote unquote, mostly from the medical community and those who deal with DCIS and breast cancer every day. Unfortunately, a lot of times the language that's used can create some fearful mindsets, right? Especially as you're going through the process. They're going to be talking to you about, well, here's a suspicious something. It could be cancer. So, you know, so you're already kind of thinking, oh my gosh, what's going on? And if it's labeled DCIS, we're going to talk about that and what that means too. Just so you know, there are some of us, as I mentioned before, patient advocate teams and leadership teams that are trying to help create better communication about DCIS and help doctors understand this last bullet is more for them than for you, is that DCIS may be the first time someone has ever experienced cancer or the cancer world, meaning the medical world, as well as what it's like to live with that. So I thought we'd start with what is DCIS, and DCIS is ductal carcinoma in situ, which is a breast condition that includes abnormal cells, but they stay in the milk duct, which is the tube basically that you see here in this picture. That's the duct, the tube where milk flows from where it's created to the nipple area. And that's in this picture. I can't see because my menu is in the way here. Sorry. And that carcinoma, which is another word for cancer, is a disease that's where some of the cells grow uncontrollably and can spread to other parts of the body. The key word there is can spread. It doesn't mean they will spread. Okay. So that's something to remember. Um, and so we'll talk about that. Cancer means uncontrolled growth. That's what it means. And when it's DCIS, that means it stays in place inside the milk duct itself. And DCIS has many, many different names. And I've got many of them listed here. I won't go over them. You will have the slides and, of course, the recording afterwards. But this is where we want to ask you a question now. So Victoria's going to get a poll set up for us. And that poll is for you to answer one of these items. What sounds better to you? And I'll say these while you're filling out the poll. Non-cancerous lesion is DCIS a stage 0 breast cancer? Abnormal cells that look like cancer? Precancerous lesion? A non-obligate precursor to breast cancer, non-invasive breast cancer, or breast disease. So if you could pick one of those that sounds better to you, that would be great. And then we'll see the results here in just a minute. By the way, these are all terms that doctors use and or are used in publications about DCIS. So that's where these words come from, as well as some of them that we're trying to change. How are we looking, Victoria?
Almost there. I'll share the results.
Okay. Okay. Well, this is interesting. I didn't figure we would have a majority of anyone, but non-cancerous lesion seems to be leading, and then stage 0 breast cancer. Okay, thank you very much. That's helpful. So appreciate it. So DCIS is confusing, as we all know. And it starts with screening, usually mammography has been what has been there. And it's been improving through the years. And then what happens is your doctor says, or the radiologist says, oh, you've got an abnormal finding, you need to go further. So then there's a host of doctors who diagnose DCIS, doctors who treat it. There's research that's being done all over the place in different ways. There are clinical guidelines that are set for DCIS. There can be risk tests and commercial products that are developed, decisions and treatments that have to be decided upon, what you're going to do, if you're going to do active monitoring or if you're going to get treated in any way. And then you live the rest of your life knowing that you have had DCIS and you have to figure out how to put that back together again as well. So I'm going to kind of go through these steps that you see here in this graphic, and we're going to start with screening. But before we do that, I just think it's important to put DCIS in perspective, okay? It is serious, but it's not necessarily life-threatening. So studies have gone on, and there have been multiple studies that show that people, and women primarily, with DCIS actually live as long, sometimes even longer than the general population. So what the heck does that mean? Well, out of the, and these numbers are from 2015, so they're even bigger now. Out of the 75 million women who are over 40 years old in the US, this is US only, about 26 million get screened. Out of that, they find IBC, which is invasive breast cancer, and DCIS. So this chart is just on those two areas. As you can see, there are recurrences for invasive breast cancer and deaths, unfortunately, per year. For DCIS, if you have DCIS, this is your side. So there are lots of women, about 20, even up to now 25% of women who are diagnosed with, quote, breast cancer in the breast cancer statistics are actually diagnosed with DCIS. And in a 10-year period, there will be roughly about 10% that will be have a recurrence of DCIS. and about 10% that will get invasive breast cancer. The statistics on that are that normally the invasive breast cancer that is found is an early stage breast cancer, not a late stage breast cancer. Sometimes that can progress. As you can see here, a few people do die of this approach. They don't die of DCIS. They die if they get invasive breast cancer. And this number is actually a 0.1%. So it's a tenth of 1% who do die. So as you can see, you actually have more risk of dying of something else than you do of DCIS or invasive breast cancer. So there, as I said, a lot of the studies, more women die of cardiovascular disease and then of other causes than of breast cancer or DCIS. So DCIS, where did it come from? It's always been around, but there are older autopsy reports that show that women have died with DCIS and even invasive breast cancer in their bodies when they died of something else at whatever age they would be into the 80s and 90s. So DCIS increased with the increased rate of mammography machines. Okay, so as mammography became more popular and most hospitals or clinics got a mammography machine, DCIS was also increasing as far as risk. And this only goes to 91, but the rates continue to go up. So when you talk about screening mammograms, more breast cancer was found, more DCIS was found, but there was no change in the overall death rates, which means that some women are being overtreated for DCIS and frankly, even for breast cancer. One of the trends right now for invasive breast cancer is how can we lower the amount of treatment so that we're not doing overtreatment and women are suffering the consequences of that. So we're looking at that in DCIS as well. This was from a study in from the University of Oslo, and they showed with their estimates that about 3 in 10 women who are getting DCIS were being overtreated. So there is a difference in screening from diagnostic mammograms. So I wanted to be sure and go over that too. And mammogram has been the primary method that we use for identifying certainly DCIS. Almost 90% of DCIS is found on a mammogram, not found in any other way. And so, that's early detection. That means that this is what's suggested for populations, right? Not just an individual person, but we're telling women over 40 that they need to get at least a baseline mammogram so we know what's happening. They can identify abnormal activity that's going on in the breast, sometimes very small cancers. And part of that is found through calcifications. Calcifications mean that there's like a mineral deposit of calcium there, right? And there can be lots of reasons for that. It can mean there can be benign tumors or lesions. It can be DCIS, or it could even be invasive breast cancer. So that leads to the diagnostic side of things. And diagnostic mammograms are used after screening shows something abnormal. So you get more images and more magnifications. They usually want you to come back for that. And there are other types of methods that can be used that are listed here for that. It is ordered by a doctor. It's not something you can do on your own. So you can get a screening mammogram on your own, but it's only if there's some kind of abnormality that you get a diagnostic mammogram. So with that, and all of these conditions that are listed here were found on mammograms as well. The real question is, why is DCIS treated more like invasive breast cancer than these other conditions? And as you can see, some of the others, like LCIS, is lobular carcinoma in situ, has cancer cells inside of it, just like DCIS does. So the reason why there's a question of whether or not it's cancer or not is because there are cancer cells, abnormal cells that are in the milk duct, but they don't go outside of it. And one of the features usually of cancer is that it invades other places. So out of this, you've got the LCIS is in the milk gland where the milk is actually produced, not in the duct or the tube where the milk goes. And yeah, I'll just do this one. There isn't a lot of difference between atypical ductal hyperplasia, which a lot of women are diagnosed with from the mammogram. It is also in the milk duct, just like DCIS. It its actual requirement is that it doesn't have all of the required features that a DCIS does. And arbitrarily, and according to one of these articles, they define it as being under 2 millimeters in size. And DCIS, if it's bigger than that, then they usually label it DCIS. And as you can see here, we've got this little cartoon that talks about how they think things develop, abnormal cells develop, and then develop into cancer. Now, we're not sure, and not all invasive breast cancers come from this model. So that's another reason it can get confusing. But 2 millimeters, if you think about that or you look on it, that's less than an eighth of an inch. So if any of you sew, you know that that's a very, very small seam margin. And so that's the main difference between ADH and DCIS. They can be treated very differently as well. So how is DCIS found? Well, it's found with a biopsy that collects a small sample of breast tissue. And you can see there in the diagram, it shows you a little bit of information there. And then a doctor named a pathologist will examine it and write a report about what's in that sample of breast tissue. Now, a pathologist is probably one of the most important doctors you will never meet or rarely meet, because they're the ones who look under the microscope and actually do the diagnosis and create the report that is then used to try to figure out what to do about it. One of the things that is important to remember is that in a biopsy, they're taking a piece of that tissue under the microscope and looking at it rather than the whole thing, because a biopsy usually doesn't collect the entire lesion or tumor sample. But the report itself will tell you what type of condition they think it is based on what they've seen under the microscope. And they do have standards. What grade it is, and the grade is actually very important. We're going to talk more about that. The hormonal status, so ERPR is estrogen receptor, progesterone receptor. Those are hormones in your body, and the lesions can be positive or negative or both. And so that's important. And then HER2 receptor status. HER2 is a marker that we have throughout our bodies, but on DCIS and breast cancer, there can be more HER2 than is normally in the body in other places. And so if you're HER2 positive or negative, that can make a difference as well in the risk factors, and we'll see that in a minute. So there are standards, but what's important to know is that each individual pathologist may have their own way of doing things. Some may be more conservative than others, which means they want to be sure that they're going to catch anything that might be possible versus more concerned about over-treatment. But most everyone wants to make sure that if there's a possibility of invasive breast cancer, that you have a diagnosis that will offer treatment for you. So when we talk about what is DCIS, I gave you the kind of the overall definition. The real key to this is how much risk is there in actually getting invasive breast cancer. Most even women who have had DCIS don't mind another DCIS as much as if it were going to be invasive breast cancer. So the grading is based on the growth factor and how abnormal or not it looks. So you can see here, you've got grade 1, looks pretty much like a normal duct. Grade 2, there's some stuff happening there, but we don't know exactly what. And grade 3 looks a little more angry, right? It's they're a little more abnormal. They're not as regimented as they are in grade 1. And there can be chemotonecrosis, is what's called dead cancer cells in the middle of it, and that can actually be a risk factor. These grades can also be called low grade, intermediate grade, and high grade. And so there's a mix of that. And the grade 1s and grade 3s are pretty easy to tell, or the low and high grade. It's the intermediate grade in there that is often has many different approaches to it. This gets into a little more detail that I'm not going to go into for you, but there are basically 6 different types of shapes that can be involved in the breast ducts with these cells. And so these shapes make a difference. The only one we need to really care about at this point is chemotonecrosis, which is this one. When that exists and there are dead cells in there, that can lead to a little higher risk, and that's labeled a grade 3. So it is important to know what grade DCIS you had. The other thing is these are usually, not always, but usually things that go with a grade 1. Slower growing, they're smaller, they're ERPR positive, HER2 negative, whereas larger, faster growing ones that are ERPR negative and HER2 positive are usually in the grade 3 category. Not always, but can be. One of the things that's really important to know is that a large proportion of DCIS has a mixture of these 6 different types of shapes. And so it can be difficult to categorize, and that's one reason why it can be so confusing. It can be important to get a second pathology opinion, especially if you're in the grade 2 or in a mixed kind of situation. How many opinions? One other opinion is usually good. You can have multiple ones. Sometimes they don't agree, but depending on what your situation is, it can be useful to get more opinions than just the first one that is given. I also want to make sure that you know that in microinvasion, if that word is ever used, just think of stage 1 invasive breast cancer. I'm not going to talk anymore about DCIS with microinvasion. It can be called different things as are listed here, but it basically is considered and is treated as if it were stage 1 breast cancer. So we have another poll for you, and we'd like to know what type of DCIS you have had, if you've had any. If you haven't had any, then that would be number 5. And if you're not sure if you've had it or not, there's an answer for that one as well. So please go ahead and take the poll, and we'll show the results here in just a minute. And I'm going to have to speed up. Okay, so we have a mix. And some of you do know what you've had. Very few people don't. Okay, that's good. So moving on. Just to give you an idea, again, I'm going over this a little bit on what the biology is of DCIS, so you know what that means. So this study was done in 2015, but all grades, this is showing basically what the survival rate is for women who had surgery, this line in dark, and then the dotted line did not have surgery. So this is about the only study we have of what's called natural history, right? If you didn't have surgery, what would happen? And so for grade 1, you see here the rates are very, very similar between surviving a 10-year period if you had surgery or didn't have surgery. If you had grade 2, the lines begin to separate a little bit more. And for grade 3, they separate a little bit more. So this is why for grade 3, there is a difference in what people are suggesting for treatment than for grade 1 or grade 2. So this is how it works for treatment. Active monitoring, or sometimes it's called active surveillance, is where you go in on a regular basis, usually yearly, to once you've been diagnosed with DCIS, you go in for mammography or screening on a regular basis. And if things change, then you can consider surgery and other therapies versus having surgery immediately. There have been a couple studies that show that it doesn't seem to make a difference whether or not you have surgery immediately or if you do active monitoring, if you're low risk, right? The low or grade 1. Same thing for intermediate or grade 2. It's a little bit different for grade 3, so I'll go through that. For grade 3, doctors definitely suggest surgery, whether it's a lumpectomy or a mastectomy is a conversation to have with your doctor and for you to make a decision about that. Endocrine or hormonal therapy is sometimes used as well, and that depends on those markers I talked about, the ERPR marker. If it's positive, then sometimes your doctor may suggest that you have hormonal therapy. Radiation is possible. Most often that's used if you have a lumpectomy. And I'll explain a little bit about that. Surgery and radiation focus on that local area. So they focus on your breast. That's done in case there might be any cells they didn't get in surgery. So they're trying to make sure about that. Endocrine therapy it kind of handles the whole body, right? It's what's called systemic therapy. So it's going to look for different cells in different places, both in the breast and through your bloodstream, and try to take care of any remaining cells that are there. And then, of course, diet and exercise are always a useful thing to consider and take care of. The studies have not shown that diet or exercise makes any difference in survival rates. Now, something that's really important about treatment is that risk factors exist for everything, okay, all across the board. So you need to be thinking about, okay, well, what does that mean? If I got a lumpectomy, what would that mean? If I got a mastectomy, what would that mean? If I did active monitoring or surveillance, what would that mean? There are similar survival rates for both lumpectomy and for mastectomy. And lumpectomy, whether or not you have radiation, the survival rates are still very, very similar. The difference that radiation makes is whether or not you're going to have a local recurrence in your breast. And then sometimes at surgery, they can find invasive breast cancer. Remember, I showed you that they don't necessarily see the whole tumor or lesion until they do surgery and actually take out the whole thing. So there can be invasive breast cancer found during surgery. They're also looking at that with the studies that are going on with active monitoring to see if there are the same levels of identification there. So radiation, again, can lower your local recurrence of a future DCIS or invasive breast cancer, but it doesn't impact your survival length of time. And hormonal therapy is usually considered tamoxifen for premenopausal, although there can be a couple other drugs there as well, or what's called an aromatase inhibitor for postmenopausal. That means if you're still having periods or if you don't have monthly periods anymore. The real key message here is that you have time to decide no matter what type of grade you have in DCIS. DCIS is not an emergency. There is no right answer. It's what matters most to you. So it is a personal preference between these different types of possibilities. And again, here's an example of an article that shows a study where women who have DCIS have a slightly lower risk for dying of anything than the normal population does. So, and part of that is because you're being screened more often, right? And you're going to the doctor more often than the general population does. The other thing that's important, and I bring this up with the medical community, this slide is often for them, is to help understand that DCIS really is different for every body, as Megan Clare said yesterday. And so it's important to make sure that we handle the psychological part of this as well as the physical part of this. And the medical community hasn't always been good about doing that. So again, we're trying to help make sure that happens. Financial concerns, treatments can be very expensive. And so even DCIS, even surgery and all of that, depending on whether or not you have insurance, what your deductibles are, all of that, we need information on that for you to make a good decision. And also, sometimes you're if you try to get in support groups and talk to other people that have had invasive breast cancer, they may say, well, you have nothing to worry about. You just had DCIS. And yet it's still very confusing. So there are a lot of issues about what need to be addressed and how people need to talk. Now I'm going to very briefly go through low risk versus high risk. And as you can see from this quote, Dr. McIntosh is kind of giving what we know research wise, that generally low and intermediate grades, grade 1 and 2, are considered low risk with the lowest chance of becoming an invasive cancer or even recurring with DCIS. And there is evidence, and we're doing more research to find out that if it's left untreated, most of the time it's not going to cause a problem. At least 8 out of 10 women who have DCIS will not have another breast event. So these are factors for low risk, and I mentioned this before. So this is something to keep in mind. If you're older, if you have ERPR positive and HER2 negative, those are all low risk DCIS factors. When we talk about active monitoring instead of surgery, there are several trials that are going on internationally. And as you can see, the COMET study here is in the US. This is basically looking at active monitoring versus surgery. And what they're trying to do is see if there is any difference at all in recurrence rates and in survival for this. Almost 1,000 patients have now enrolled in the COMET study, and it is closed to enrollment, so no one else can enter the study. But a lot of information we have to wait for before it's possible that this could be important to change clinical practice on. So the study is still being analyzed, and data are still being collected on these women so that we know if there are any differences between active monitoring and surgery and what those differences might be. Again, that's for low risk. This is an example of the way we're trying to change the language that doctors use and that patients use, right? The patient community as well. This is what's currently being used, and this is what we're suggesting. There really are different kinds of DCIS that have differences in treatment and things to consider. So I am running out of time, and I want to make sure we have time for your questions. This is another example of a different research project, or a couple of them actually. So this is the COMET study itself, and the websites are here at the bottom that you can go to. But we thought that it was really important to start talking about the treatment approaches, because they are both treatment approaches, whether it's surgery or active monitoring, and what that really means. So what the treatment approach is, what the goal or the aim is of the approach, details about the approach. So what's done, what would you expect? What's happening with hospital stays, time off of work, endocrine therapy or not? That's not a part of the study. That's up to each individual doctor and patient to decide whether endocrine therapy would be important. What are the common side effects, both from surgery and from active monitoring, and then less common side effects for each one. And then another DCIS research project that's trying to find identifiers for even more detail about how to differentiate between low risk and higher risk. We've done some plain language summaries of information here that you can, this is an example of one of those when you go to the website. And in particular, we've put together some ideas on low risk DCIS research and resources. So this is a 2-page document that talks about what the research study is, what we currently know about DCIS, that it's frequently detected with mammography, biopsy, the things that we've gone over here, that it can be surgically removed, but it can also be looked at through active monitoring. And then the difference in grades, the current treatments that are available, clinical trials that are available or have been, how to improve communicating about risk for everyone where there are resources. So that gives you an idea of some information that's there. Here are some risk factors that we know add to the risk of invasive breast cancer in a 10-year period, okay? So if your DCIS was found by feel, right, rather than mammography, that's a big one. High grade, grade 3, unclear margins. So in other words, if it's the margin is the outline where they took out the lesion, how much space was there around it that was clear of DCIS? So again, the margin is 2 millimeters, less than an eighth of an inch. If there were still some possibilities of cancer cells in that margin, that's a higher risk. The size of the DCIS can be a risk. Being premenopausal, being younger, African American ancestry, unfortunately, is a higher risk. A marker that is not normally used in the clinic, and then less access. Also, if you have BRCA1 or 2 or another genetic marker, there's an indication that there could be a higher risk. But again, usually the invasive breast cancer is one of the earlier stages, stage 1 or 2, that's there. And just for emphasis, everyone recommends treatment for grade 3 DCIS. These are tests that come up, and I know I've been over time. You guys probably have heard about some of these tests. One thing to know about, these tests are for risk of or benefit of radiation therapy. Is that something that you should consider or not? So it's possible to get a little more information about if you're going to have surgery and a lumpectomy, do you want radiation or not? It depends on some of these risk scores. But one thing that's really important to remember about risk is there's a difference between the risk that sometimes the researchers and the medical community talk about, which is a relative risk, versus your absolute risk. Okay. So an example of that is when they did the studies on whether or not you should take tamoxifen when you don't have breast cancer to try to reduce your risk. They said there was a 50% improvement in risk reduction for women that took tamoxifen. You know what that meant? An absolute risk went from 2.3 to 1.6% that a woman had a risk of getting breast cancer for that year, each year. So that's why it's important to know the difference between what kind of risk are they talking about. And this is a really good article from Mayo Clinic about that. So, be sure and take a look at it. I tried to include links on all of the articles and information that I found. So to take away, basically, DCIS is becoming clearer, but it never gets done as quickly as we all want it to, right? There are resources there, and I've listed some of them here. DCIS 411 is a blog that Donna Pinto has, and she researches a lot of her work that she puts on there as well. And then if you do get it, you do have time. So you have lots of time to make a decision about whether or not you have surgery right away or if you wait, in the case of low risk, it is definitely a trade-off between what's your future risk of getting invasive breast cancer and what treatment effects or consequences you have. There are some decision tools, and that was on one of the slides I had on the COMET study. And, you know, just get as much information as you can. Yes, it's confusing. Sorry about that. But there are a lot of ways to find out more about it. And please do join us in February. This is just a thing. Dr. Shelley Wong will join me when we talk about some of the latest research that is looking quite promising. So with that, I will stop and let Megan Claire pose some questions.
Yes. So Deborah, I want to first ask, are you okay if we go a little bit over? Because I really do want to get to quite a few of these questions. Okay, fantastic. Yes, everyone, we are now in the Q&A portion here, and we have received quite a bit live and also those that were submitted with registration. And, you know, as you're talking about like the risk and then like even thinking of active monitoring, what is considered active monitoring for DCIS patients who have immediate family history of cancer?
Okay. Immediate family history is one of those things that may or may not be a higher risk. Okay, if you actually get genetic testing for what they call BRCA or BRCA1 or 2 or some of the other genetic markers, then that can determine whether or not you might be at higher risk. And so if you get the genetic test, there is more thought that it might be good to have surgery instead of active monitoring. But the thing to remember about active monitoring is that it doesn't mean you would never get surgery. It means that you don't need to get surgery right away. And so far, studies have shown that there doesn't seem to be a difference in overall survival or recurrence if you wait for surgery or not, because they're going to be watching you closely. That's why it's active monitoring, right? So if anything starts to change, then you can make a decision whether or not you want to have surgery.
I feel like that's very psychological too. Like
It is.
that's really gonna mess with your head of should I just go ahead and get surgery now versus waiting?
It's
I would
not, yeah, it's not for everyone. The thing to remember is that surgery has consequences and side effects as well. So there can be complications from surgery. There can be lymphedema. There can be, infections. It's, and it sounds like, oh, well, why don't I just go ahead and have a double mastectomy prophylactic and take care of this and get reconstruction? No problem. That can certainly be done. That definitely most doctors and frankly, patient communities feel that that's overkill, right? Way over treatment. But the issue is if that's what's really good for you, okay. But remember that surgery has complications. You need to know about those ahead of time going into it. So look at like the information that we've tried to put together between surgery and active monitoring to make a decision that's right for you, right? That's the whole key. Is it's about the level of risk you feel you can live with or not. And frankly, I do have to say, surgery is not 100% risk-free. There's still some breast tissue around that can, and women have been known to get invasive breast cancer after surgery, even a double mastectomy. And the other thing to remember about that is with reconstruction, you lose feeling, okay, in your skin and also in your nipples. So you have to kind of keep that in mind as well. If that's something you think you're okay with, then that's a part of your decision-making process.
and speaking of that, I just want to highlight this I guess comment and question that we just got saying, I've read that even if you have a mastectomy for DCIS, you can still get invasive breast cancer. I don't understand. How can you get breast cancer if you don't have a breast?
Have a breast. Right. It's not just the physical shape, right? So I'm not going to do an anatomy lesson here. However, basically you need to think about, you've got breast tissue from the your collarbone down to below your breast and then up through your underarm area. So it's a big square of where breast tissue can be. It's not just the part that sticks out. Okay. Um, so and there's always some tissue that is left in there, even when it's a mastectomy and you don't have any type of reconstruction or whatever, there's still some breast tissue left. So it's rare, but it does happen. And nothing in life is risk-free. I think that's what we have to remember. I once looked at statistics and it's like a 94.3% chance of living through today. So, it's nothing is risk-free. You can certainly reduce your risk, but just know that living with DCIS does not have to be full of fear every day. There are precautions you can take. There are things that we can learn and are still learning about the different levels of DCIS. But you need to think about, what is it that I'm going to be able to live with and move forward with without facing fear every day.
Yeah, so true. Um, so you did touch on this, but is hormone therapy really needed for DCIS?
Well, you're going to get a different answer from me than you probably will from a lot of doctors. Um, is it really needed? I think in some very small percentage of cases, perhaps, is my best answer. I won't say yes. I would say no more often than yes, but there are some cases where it may make sense, like family history, or genetic testing with HER2 or ERPR positive grade 3 HER2 negative. That's along the lines where you may want to actually consider hormone therapy or endocrine therapy. Um, but those cases are not uh, common, I guess I should say.
Mm, okay. This is an interesting question, and it kind of goes with this other question I just saw in the chat of let's see, if you had DCIS and then you were diagnosed with triple negative breast cancer, was that caused by the DCIS?
You need to come to the February 6th webinar. um, the answer is maybe. So what they have learned in one of the research studies that some of us have been involved in is that not every DCIS uh, produces, or not every invasive breast cancer from someone who had DCIS comes from that DCIS. Okay.
Mm-hmm.
A lot of it does. So I think like 80% are the same kind of cells. That's how they look at it, from the DCIS to the invasive breast cancer in the same breast. Okay. But 20% of the time, it doesn't happen that way. So it could be like a brand new cancer, right?
Mm-hmm.
Not connected to the DCIS at all. Most of the time, it looks like it may be, but not all the time, which is another reason why this gets so confusing.
Right, right. What is the difference between DCIS versus non-DCIS breast cancer?
Okay. Non-DCIS breast cancer is called invasive breast cancer. Now, there are different types. Okay. There's invasive ductal carcinoma, which is in that milk duct. There's invasive lobular carcinoma, which is in the milk gland itself, where milk is created. And then there can be other types, but those are the two main types. Um, so if it's non-DCIS breast cancer, it's most probably considered invasive breast cancer of some kind. Did that answer it?
Yeah, and I'll just remind everyone, Deborah had a really great slide that showed that visually of, DCIS, and then if it's invasive, how it goes outside of it.
Yeah, let me see if I
So
can find that one while we're
yeah, that'd be
talking.
great to put that back up. I think that just might
Okay.
help.
Like this one?
Let's see, which one was
Are
that?
you, I think that's slide 12.
Okay.
Is that showing at all?
Not yet, no.
Oh, okay. Hold on. Let me stop sharing and I'll reshare when I get it. Go ahead and ask another question and we'll go back.
I think someone's asking if you could repeat what you just said. Hold tight. She's going to pull up that slide and repeat what she just said.
Yeah,
Yeah.
I'll just list it like this.
Okay.
So if it's not considered DCIS, it's non-DCIS breast cancer, okay, then it would be considered invasive breast cancer, whether it's invasive ductal carcinoma, which is in the tube, or invasive lobular carcinoma, which is in the milk gland itself, the ending gland, which was, hold on just a minute. Oh, I went the wrong way. Sorry. All right, so there's that one. Well, I'm not going to get to it quickly here, so go ahead and
Okay. Okay.
let's move on and I'll see if I can find it.
Okay.
Yep, here we go. Okay, so we've got the lobule is basically the blob on the end, right? That's where the milk is produced, starts, and then the duct is the tube where the milk goes to the nipple. And this isn't a great drawing because it makes it look like everything is very uniform. It's like tree branches, right? So the duct, there can be multiple ducts and multiple lobules. And so that's why sometimes DCIS is in different parts of the breast, right? And invasive breast cancer just means that it went outside the duct and may be affecting other parts of the ductal system
Hmm.
that's there.
Okay. So there were some questions about in in the slide where you showed the treatment options, and it mentions you know, potentially radiation, but how come chemo isn't recommended as a treatment option?
Right. Chemo is not recommended as a treatment option because they've actually done some studies that show that chemo did no good with DCIS. That's definitely over treatment for DCIS. Okay. And again, the reason for that is DCIS is contained, right? It's contained in the milk duct. So the chemo is for the whole body and it's not really getting um, to the cells in the milk duct as well as it would for invasive breast cancer, where it might be outside of the milk duct. Part of that has to do with blood supply and stuff like that too, but I won't go into all of that.
Okay. I really, I love this one comment here where she says, I know I'm not the only woman with high grade DCIS who has said no to all this standard of care treatment. So why is no one interested in studying us?
I don't think they're not interested in studying you. Part of it is, what can they get money for? Frankly, that's a part of it. Um, I think that now that we have more information, real world data, right? We may be able to have more studies done with high grade DCIS, both that's treated in all of these different ways, as well as active monitoring. And there are some women that decide to do active monitoring with high grade and they're fine.
Mhm.
Sometimes it will progress, but sometimes it won't. So that definitely is a choice and each person has to decide what is right for you. Getting more information about it and what happens with each of these choices. The main thing is the consequences, right? Not only the risk factors, but the side effects for each of these treatments is really what I meant there, as I should have put in as well as risk factors. There are side effects from everything. So you as long as you go in knowing what that is, then making a decision that's right for you, then that's the decision that's right for you. But again, that may not be the decision that's right for everybody.
Right, right. So here's another question. Are the cells different for DCIS than for invasive, or how, or do the cell, wait, or do the DCIS cells bust out and then become actual cancer?
Okay. The cells themselves are classified as cancer cells. So they're abnormal growths. Okay. And um, and again, the size of the DCIS lesion means that some of them have grown more and they're bigger than others. Okay. Or there may be more of those cells there than in others. Um, some of them may escape the duct and turn into invasive breast cancer by definition. That means they go throughout the breast. They may go into the lymph nodes, and that's how they get to other parts of your body. Or, so are they the same cells? Classically, yes. They are called cancer cells. Okay. The main difference is where are they and what can they do? A lot of DCIS will never become invasive. Most of it, in fact, like I said, about at least 8 out of 10 women will never have that issue. Actually, it's 9 out of 10 women because only half of it becomes invasive. Um, so did I answer that question?
Yeah, I think so. And you can let us know in the chat. A follow-up on that question. Can they see those cells that break out into the breast tissue? If so, how?
Okay, well, that's how invasive breast cancer is diagnosed. So, yes, they can because there's like they call it a membrane or a border, right? There are cells that line the duct, and that's usually what becomes cancer cells. When they stay in the duct, it's pretty clear. When they start to invade, it gets kind of chaotic, right? And they can see where they're not in the tube anymore. They may have gone into the fat area, or they may have gone into the structure, which is called stroma, and I won't get into that, but other parts of the breast area. So they can see that, and that's done through a biopsy primarily. Or even another surgery, but usually through a biopsy.
All right, I'm gonna ask 2 more questions and then we'll wrap it up. Because
Okay.
some of these, and y'all are asking amazing questions, we can answer those in our part 2 in February. Okay, so I don't want you to think that your questions are going to be ignored, but some of these would be really awesome to have Dr. Lang on. Why are some doctors doing sentinel lymph node biopsies for DCIS? Is that common?
It is not common, but again, depending on the grade and the location of the tumor, if it's close to a sentinel lymph node, some doctors, and again, that's where they're being more conservative, where they want to make sure they take every precaution and every possibility of finding out if there's anything else there, they might take a sentinel lymph node. It's actually something that's changing right now in the medical community based on research, because what I've seen, and I'm sorry I don't have references for this, and hopefully in February's call we can deal with this. There hasn't shown to be sentinel lymph nodes have not been shown to be that effective for DCIS. That's more for invasive breast cancer.
Okay.
But it is being done sometimes.
So we're gonna end on this last question here.
For
Are
our
there
poll,
our
Victoria, if you
poll?
can call that up. Oh, sorry. No, go ahead, Megan, Claire,
I
go
was just
ahead.
gonna say the one last question, and I want to make sure that Victoria captured that other question that the initials MF asked in there, so we can put that in for our February one. So just make sure you put that in our script here. What are some good questions to ask before meeting with the surgeon if you have been diagnosed with DCIS?
Okay, I think one of the good questions would be, what grade of DCIS do I have? Do you consider it low risk or higher risk? And remember, higher risk is still very low. So it's kind of a misnomer to call it high risk, but it's high risk DCIS, not high risk breast cancer. Okay. And then, what would be some of the things to expect if you considered active monitoring? What would you need to expect if you considered a lumpectomy or a mastectomy, and see what they have to say. Reconstruction is a part of what that discussion should probably be. By the way, you can have reconstruction on a lumpectomy as well as a mastectomy. It's different, but it can still be done.
Okay. So thank you so much. Let's get up our last poll here.
Yep, Victoria is going to bring that up for us. And what we would like to know is if you feel less anxious or not after hearing this program, or if there was no change. So please answer these. That will help us a lot. And I look forward to seeing all of your questions. I haven't seen them yet, so that we can cover as many as possible in the February call, as Megan Claire said.
Absolutely. Okay.
Okay. Oh, well, good. It's about half and half. That's actually better than I expected. So thank you. I hope that I haven't confused the issue even more. I'll just say they're in the slides that I have, and now it's on the recording as well. There are some resources here that you can look into, some of which I've already talked about, some of which I haven't. One is I did a Share DCIS webinar in 2021. A lot of that information is still relevant. So if you'd like to look at that before the February webinar, please feel free. And then just thank you very much. Looking forward to having more discussion and more questions from you in February.
And absolutely. And everyone, just so you know, once this recording is ready to be on our website, we'll pull out those links so it'll be easy for you to click on. So I just want to make you aware of that. And again, Deborah, amazing. Thank you so much insight. And I really feel that those who want to learn about DCIS or have appointments coming up or have already been diagnosed with it have walked away with a lot more knowledge and other additional questions that they may want to ask their medical team. So thank you so much for being with us today. We look forward to seeing everyone next month for the second part of our series. So make sure to join us then. We have captured all of the additional questions that would be great for our February program. And check out our upcoming events that we have, and take a moment to fill out our survey that'll pop up as soon as we end this webinar. They are anonymous, and we do read all of the feedback. So this concludes our webinar. Thank you so much, everyone, and have a great rest of your week.
Thank you. I appreciate being able to talk to you guys.